Good afternoon and welcome to Module 2 of Coming to the Table, a Pediatric Primary Care Healthy Weight Initiative for Children and Families. My name is Elizabeth Breitenbach. I'm a meeting and event specialist based in the Clinical Affairs Division here at NAC, and I'm pleased to bring you this event along with my division colleagues. Before we get started, let's review a few housekeeping announcements. First things first, by joining this online Zoom event, you automatically consent to this recording. Again, this event is being recorded today, available for playback at a later date. Joining this session automatically consents you to this recording. You have either joined in by either using computer audio or physically calling in. Either option, completely fine. I always recommend, though, that if you're in an area where Wi-Fi can be a little bit spotty, it's best to typically call in so you can hear the entire event. Muting, unmuting video, all of those features are available within Zoom. We do ask that if you're not contributing verbally to the conversation, please keep your audio line muted. This is to avoid any sort of background noise interference. And we want to see your faces today. There's going to be times where we're going to go ahead and remove the PowerPoints, especially during our Q&A section, so we can see everybody. So it's a little bit more interactive, but you do have the ability to share your video as well today. And of course, you know it, you love it. Chat box is open, located either on the top of your ribbon or the lower right-hand side of your computer screen. Simply type your comments, questions, or concerns into this box at any time. And just for a little fun little icebreaker, similar to last week, where are you coming from today? Let us know where you're working at, maybe city, state, your health center name, or even like where you're physically working at. Maybe you're working from home or directly in the office. Let's hear it from you guys. Friendly reminders, today's event is being recorded. Keep your audio lines muted. This is to avoid any sort of background noise interference, and the chat box is open. At this time, I'm going to turn things over to Jenny, who's going to be moderating and taking it from here. The floor is yours.
Thanks, Liz. You do such a great job with that. Welcome to the table, everybody. It's sort of lunchtime around the country, so that'd be interesting too if you all have had a chance to come to your lunch table, but we're glad you're at this table. Next slide. For those of you who were here last week, we're glad you're back. For any who are joining us, last week's module has been recorded and is available, and also for review. Our theme has come to the table because it takes all of us to address pediatric healthy weight. And this week's particular sub-theme is called Choosing and Tasting Menu. We're really going to pay attention to whether what we're offering to people is attractive to them, and particularly around language and communication. So we're so delighted that we have some guests that will be helping us with this understanding. We'll start with meaningful work like we do every time, because we want this to be a time of refreshment, a time to remind us all why we're doing this sort of thing and not just trying to pound more information into our heads. And also we try to link that meaningful work moment with the topic and how we might better help the families that we serve. Our big topic today is around bias and stigma in weight management, and considering some of the newer ideas, such as healthy at every size, which is the name of a particular movement. We're going to look some at the relationship of culture to food, which of course is huge. And evidence-based, we said last time that motivational interviewing is one of the pillars of evidence-based care around healthy weight. So we're going to do a deep dive into that and give you a chance to interact. Like Liz said, there will be some times for you to practice some things, times to chat, and we'll have case examples from Denver Health, which we're real excited about. Next slide. So this week, chefs, we're delighted to have Doctors Haley Ringwood and Brenda Prabhakar-Gippert from Denver Health. And they are a dynamic duo who are going to be sharing with us their own experiences in a program called MEND, as well as further programs in addressing pediatric weight management. And Jessica Wallace, we mentioned last week, is going to work with us some more this week, and she is at Denver Health as well, and will give us an introduction to Haley and Brenda in just in a few minutes. In addition to that, we've got some other people who are subject matter experts on this module, and we know that. And included among them are our CDC funders. So Dr. Allie Goodman may chime in on chat. We may ask her to elucidate on some things. And any of you who consider yourself a subject matter expert, or even somebody who's got really good experience in the particular topic at hand, we're always interested in your comments on the chat. We're interested in your questions, examples, rebuttals, whatever. We'd like the chat to be really useful and collaborative. Next slide. So let's just start with our meaningful work moment as we come to the table now and we think about appetizing communication. I want you to think about what your titles are as a person, okay? I introduced just briefly some folks as doctor. I have that title. I also have the title of Mrs. I have the title of mom, sister, doubles player, doubles partner. So think about what your titles are as a person and how they make you feel. Think also about how you like to be addressed, and maybe that's different in different environments. For me, it was a shock to move to the Pacific Northwest and have small children address me as Jenny. I wasn't used to that because I came from the South and they addressed me by either Mrs. McLaurin or Dr. McLaurin. And I know that when I worked in a public health clinic in North Carolina, and we had a very young Northern young woman who became the director, she thought she'd be egalitarian and gave us all name tags with our first name in huge print and our last name tiny somewhere. And our older Black nurses were not the least bit happy because they did not call each other in public in their professional setting by their first name, and nor did they want their patients to, which has historical racial reasons behind that. And so how we get addressed, what we get called really matters to how we feel about ourselves. So we're going to think about that. We're also going to think about our bodies and how we feel about our bodies. So a lot of times we're very critiquing of bodies, but I want you to spend a second and think about what you love about your body. I love that I can play tennis. I'm thrilled. So think about how these issues bring you joy or discouragement, and feel free to share any of that in the chat as we go. And think about it as you meet with your families, how they might want to be held up as human beings who inhabit a body and navigate all sorts of different places in this world other than our health centers. Next slide. We were grateful to receive a presentation, the PowerPoint, by Dr. Nikita Williams, who really did this more as a research project within the CDC, and Dr. Goodman shared it with us. And she did a really wonderful PowerPoint on how words, culture, bias, and stigma really are seen in the world of pediatric obesity and overweight management, as well as healthy weight. And there was a little bit on culture, not as much as maybe she hoped, but also a really nice piece on motivational interviewing and its impact. So we're going to extract some of what she had in addition to the ongoing research and in addition to the lived experience of our speakers. Next slide. So one of the things that came up for Dr. Williams was the challenges to screening in practice. And again, in the chat, we would love to hear whether this resonates with you, but a real reluctance of providers to initiate discussions on this topic, that there's a lot of stigma that we all recognize, even if we can't name it, around obesity and overweight, and that really makes its way into the health center and into our either reluctance in conversation or our prejudices, frankly, in conversation. And we don't want to do anything to hurt our patient-provider relationship or clinician relationship. And so Sometimes we don't say much at all because we're afraid of saying the wrong thing. Also, just the limited timing of visits really challenges our screening for healthy weight. Obviously, we talked about the COVID pandemic last time. And interestingly to me is the relationship between the rise of the anti-vax movement, vaccine, if you're not familiar, and what that means for parent engagement. I mean, that's really interesting. And the reluctance of both trust and also attendance at routine care visits. And then lastly, the rise of the body positivity movement, the healthy at every size, and how we engage with that appropriately as we also try to limit the growing obesity and overweight epidemic. Next slide. So I'd like you to now just think, and if you're with team members, that's great. We love it if there's team members getting together on these modules. But if not, just think about it yourself and think about what words you associate with the word obesity. So what word comes to mind? There's no wrong answers, and try to be honest about it. Poverty. For me, one of the words is frustrating. Unhealthy. Lazy, thank you. That is one of the very common words that pops up in research. Judgment, yep, that's another common word. Genetics. Well, your names are attached to the chat, uneducated. So I'm particularly thankful for Ashleen, who keeps putting in unhappy. Thank you, bullying. So I don't want you to think that we're judging you based on what you put in the chat, because this is just a broad question about what words do you know are associated with this. And it may be your own that you think of, but it also may be what you know other people think of. And way to show love, beautiful, not active. Fast food and salty snacks. Unhealthy is coming up a lot. So we do all have words that we associate with obesity. Unfortunately, research shows that a lot of the words that we come up with are by words that imply bias, and lazy is one of those. Next slide. There are a whole lot of other ones that are also words that are unpleasant. And basically they're blaming words, that whatever is happening with what we see visually in front of us of another human being, are many of us, not all of us, but many of us, our default instant thought is more negative than positive about their body. We don't think of them as strong or healthy. And so bias has been shown to really affect clinicians in healthcare, and implicit bias, that bias that we're not even aware of. And bias affects attitudes and beliefs and makes us stereotype, but stigma is action. So bias is how we think, stigma is how we act. So the stigma of, like, all the waiting rooms have the same size chairs, or you're getting on an airplane and you have to buy a first class ticket if you're bigger than the seat, or how job opportunities come forward for folks. So stigma is also how we treat people, of whether they deserve a good that we make available to others, and we base that whether they deserve it based on their body size. And it tends towards marginalization and exclusion. So there's been counter movements to that. I think Lizzo is a pretty famous example. And there's this idea of fat liberation, fat acceptance, even that word fat. Are you feeling uncomfortable as I say it? And then health at every size. our little cartoon characters, I want you to think about them, our cartoon icons. So they're coming towards you down the aisle in an airplane, and one of them is going to take the middle seat between you and somebody else. Do you have a preference? Does your heart go out to one of them and you want to make sure they're comfortable? I don't know. Think about it yourself. But certainly when we view somebody with a physical disability that we call having a prosthesis, I think many of us might be moved towards compassion. And when we view somebody that might have a physical disability or a chronic disease anyway, called obesity, perhaps there's less compassion. Next slide. So this is was the cover of a magazine, and it certainly has gotten a lot of play. The great body acceptance debate and this thing called healthy at every size. Next slide. And as our friend Jessica pointed out, whoops, nope, go back. Statement made from Denver Health, our guest today. Unlike talking to a patient who may not know that they have high cholesterol or high blood pressure, right? Every patient who is obese likely already knows they are at an unhealthy weight. This again reinforces that doctors or clinicians of any kind shouldn't inform their patients they're at an unhealthy weight. They should have a discussion with their patients about how their weight is impacting their health and help their patients gain the knowledge and strategies they need to obtain a healthy weight. So that's what we want to do, but we know that it's really hard for a lot of us because we haven't been really well trained how to do that. Next slide. So healthy at every size is this relatively new movement, and there's clinicians that advertise that. They have it branded on their websites and on their offices that they're a healthy at every size clinician. And it's not saying that weight doesn't matter, but the focus of it is that we want you to be healthy, that our primary focus is health and not BMI. So it doesn't focus on weight control as much. And it's gotten a lot of backlash. And so this is from their websites and what they propose. I'm not taking a stand on this, but what they encourage is eating in a flexible manner that values pleasure and honors internal cues of hunger, satiety, and appetite. I think all of us want to do that. Finding the joy in moving one's body and becoming more physically vital, accepting and respecting the natural diversity of body sizes and shapes. And that last point is something that I know I have encountered in working with Native Hawaiians, Indigenous Hawaiians, and people from Samoa, and also working in the Deep South for most of my clinical years. Next slide. So now we're going to ask you whether you have heard of that healthy at every size, HAES, and kind of what your visceral reaction is to it. All of you are interested in pediatric healthy weight. Some of you are obesity experts. How do you react to that? So first of all, just have you heard of it? Single choice, yes or no. And then how do you react to it? You can put in the chat. We're going to talk about it a little bit. Jessica, are you seeing anything in the chat there on this?
So far, so good. It's most of the comments from earlier. And then one comment that it's hard to have that attitude, but then how do you convince people to seek care, looking at obesity as a chronic disease? And yes, helping meet patients where they are.
And so 2/3 of us haven't heard of Healthy at Every Size before. I hadn't heard of it until this past year. I will say one of the best tennis pros at my tennis club is, I'm sure her BMI is very high. She's a spectacular tennis player. And she doesn't have high blood pressure, or diabetes, or anything else. And I think Venus and Serena Williams, did a lot for the world of tennis being healthy at every size in a sense. I think there's a limit to what size, though. So Jessica, do you want to sum up some more of the comments for us?
Sure. Yeah. I mean, a lot of people are saying they like the concept. They've heard of the concept. They try and integrate some of the principles into their communication with patients, while also kind of not throwing out completely the relevance of the BMI or the growth charts, and still looking at ways to reduce risk that go beyond just a number on a scale or what you look like. But everybody should read all these because they're fabulous.
Great. I'll give everybody another minute just to look at those. Like I said, we're trying to be hopefully interactive. Also, there's people that are an appropriate BMI and aren't very healthy, right? We all know that. So they don't necessarily exercise. They might eat couch potatoes and not do much else. All right, we are going to move on to the next slide. So healthy at every size is not really part of our evidence-based approach to pediatric weight, overweight, obesity, and severe obesity, but it is a reality culturally of where we are, and also something to consider in terms of how can we compassionately and honestly bring together who that whole person is, rather than just parse them out as having a certain BMI. The other way that we do that is using person-first language, and this, I still don't do it all the time because I wasn't trained that way. Eventually, I got trained around not saying diabetics, but people with diabetes. And in the same way, we're trying to remember to say children with obesity or children with unhealthy weight. If we're speaking as clinician to clinician, we're usually very technical and diagnostic, and so we may not use person-first language, but the more we practice it even among ourselves, the more likely we'll be able to use it universally. And so we want to try to speak about, in this case, we're looking at children, so that child in front of us. So we might say a teen girl who has weight-associated conditions. It takes a lot more words and more breath than saying an obese adolescent, but it also gives us a picture of a human being that's different. So we're trying to not say suffers with, that's very old, archaic anyway. I was taught not to say that years ago. And like I said, not saying like high BMI patients or anything. And going back to what we saw last week when we talked about human-centered design, that's all part of human-centered design. So would most of you, and you could just answer in the chat, would you say that you're pretty good at doing people-first language or okay? Just used one of those two choices, pretty good or okay, when it comes to talking about weight. Nice. All right, we have a nice mix, so that's good. Hopefully some of you work with each other and we can all help each other out on that. Next slide. So one of the things that Dr. Williams, who's did that presentation for the CDC, did is she did a nice job on looking at terminology preferences through the research. and what people like and don't like. And of course, again, that varies by culture, right? I think I told you last week, my Samoan babies, their mothers were delighted at their size and told me that I should really appreciate the Samoan babies. But our preferences do vary by culture and ethnicity, but nobody likes being called fat, morbidly obese, which is a term we don't really use anymore, or obese. And they don't really like the term large either. And it's interesting for children when they looked at adolescents and sort of middle-aged kids, the boys liked heavy was okay. They could be called heavy. And the girls liked curvy. That was okay. Too much weight for their health. Their parents liked that. They thought that was all right. But nobody who was addressed, whether it was a child or a parent, when they realized that the conversation, even if it was couched in the positive terminology, it still elicited some sadness and some anger on the parents' part if they thought that their child was being labeled. So the labeling brings out anger, and but the conversation can also bring out sadness just in general. So we need to realize that. Jessica, can you mention a couple of the, oh, I see it. I worked with a provider who used the term fluffy. I don't know if I would like that or not. That's interesting. Next slide. I don't think I'd want to be called fluffy. It sounds like spacey or something. So as we look at bias and stigma and we think about communication, motivational interviewing is evidence-based, and it is shown to have an ongoing lasting effect, including in the 15-minute office visit, which is what we all struggle with, and that you can do motivational interviewing in those short visits, and that it's something that needs to be repeated over and over again. So this was a study that I just came out in January, so I like seeing these newer ones, and they looked specifically at pediatricians in this study, and they wanted to see if training pediatricians in motivational interviewing around weight-related counseling was a benefit compared to pediatricians who weren't trained in it specifically for their study. Doesn't mean that they didn't know anything about it. Next slide. So what they found, I thought was pretty fascinating for all of us, is that either the patients, if they were old enough, or the parents of the pediatricians who were trained responded that they had been asked more often than the untrained pediatricians, that they had been asked about those things that we talked about last week, the 5 fruits and vegetables, the getting rid of sugary drinks, those 2 things. But what they also were asked more was their readiness for behavioral change and to set a behavioral change goal. And that was, really different. 76% readiness for behavioral change compared to 49%. To me, it was interesting that even the motivational interviewing even affected the things in that 520110 in parentheses that we talked about last week, the 5 vegetables, 2 hours or less of discretionary screen time, 1 hour physical activity or more, no sugary drinks, 10 hours of sleep, that we're supposed to be communicating that at our visits. And that has nothing to do with motivational interviewing. We're just all told to do that. And yet the ones who do motivational interviewing are much more likely to have done it. And then importantly, regardless of whether they were in that trained group or untrained group, the rest of those, the physical activity and screen time and weight status, were assessed for most patients. And most of the parents and most of the patients were satisfied with the discussion they had, but behavior change, only 21% were asked about barriers to behavior change, and that's huge. So that's where motivational interviewing really comes into play, because until we can understand the barriers, address them, and be collaborators, you know, we may not really be making a difference. Next slide. So there's 4 processes to motivational interviewing, or 5, depending on who you ask. Next slide, or just keep going through. The first is engaging. So how do you engage the parent? It's not by saying, oh, I looked at your growth chart and your child's really, golly, now they're in the obesity column. They used to be in the overweight. That's not really probably making a connection that you want to make. The second one is guiding. So jointly finding a focus together as if you're paddling a canoe together. And then evoking, it comes from the inside. It comes from the inside out, so that it becomes something they own. And then planning together. This is from Dr. Chris Bowling, who is on the section on obesity for the AAP and just finished doing a nice CME that the AAP led, that section led, and he also presented for us last year. Next slide. Next slide. Okay, so how we do it is you have to ask permission, and so using Elicit-Provide-Elicit as a form of motivational interviewing as a first step is not giving advice. It's about giving information and when to give it, and only to give it when the person wants you to give it, is ready to hear it. It's very short and it's meant to be repeated. His imagery is finger sandwiches, not a foot-long submarine. And I think we know that in practice in general, right? You're not supposed to give more than sort of 3 things for anybody, or they won't remember them. And the first step is eliciting. Permission is central before you start to give information. You give your little tidbit, and you don't forget the second elicit. And so if we're looking at that 5-2-0-1-10, we might say, oh, have you seen that before? Oh, what do you think about it? Which one of those are easy for you? Which one of those are a problem? You know, those are questions. And then if they get to say the problem, we can say, do you want to talk about that? Could I talk to you a little bit about that? And get their permission. And then we give our little tidbit. Okay, next. So we're gonna look at some Elicit-Provide-Elicit just as practice. And then after that, we're going to turn it over to our guests. But so one elicit might be, what are your thoughts about eating breakfast every day? I know my husband would say, you know, I never have, I don't like it. And then the provider would say, can I give you my thoughts on why eating breakfast can be good for you? And if they say no, say okay and laugh. Right? It's okay. We don't have to get everything every time. Maybe you can say, how about, well, then can we talk about this? And then once we give our tidbit, we just ask them what they think about it. You know, I want to hear how that hits you. And that's all it is. Next slide. Once we hear how that hits them, they say, oh, I think it's a good idea. You know, I think I should. Then the readiness ruler I've used for more than 20 years, and I love it. And you can make your own from this slide, but it's 2 things, importance and confidence. So if I say, how important would it be for you to start having breakfast right now? And they say 5. And then I say, and how confident are you that you think you could do this? They say 5. My response is, oh, cool. Well, since you said you didn't like breakfast, I think it's more important to you than I realized. Why'd you put it as a 5 and not a 3? And that helps people be positive, and the same for confidence. Oh, 5's all right. So what do you think would get you to a 6? And that's where we start seeing action take place and somebody's own thinking about what they're going to do next. You can use that for anything that you're trying to affect in healthcare. Next. So the communication strategies and research that have been shown to work in motivational interviewing and in general around healthy weight strategies that don't elicit a pushback are discussing healthy weight early and often with everybody, making it just a routine part of care. So we're not just focusing on people who are in the overweight or obese areas of the BMI. Using family preferred terms, so getting to know our families and their culture and how they think about size and health and food and the relationship of body size to joy and fulfillment in life. And then focus on health. If we hear nothing else, focus on health, not on size, and use motivational interviewing to do that. And then involving the family as a whole unit and understanding that food is such a cultural connector, and it's how we know our family, right? We all have family foods that we love. And so we don't want to get rid of all of grandma's cooking as we do this, but we want to bring everyone to the table. Next slide. So I want you to practice just for a second, and then I'm going to give our friends time because I don't want to run out of that. But I want you to turn to your neighbor or to do it in the chat and think of, it's great if you have a neighbor with you and you can do an Elicit-Provide-Elicit with them coming up with their own response to you. But if not, think of those 3 sentences that you could put in the next time you see a child in your mind who you've seen before and you really want to open up a conversation. Give us some examples that we can all use and take home from here. And while you're doing that, next slide, I would like Jessica to introduce both Dr. Haley Ringwood and Dr. Brenda Prabhakar Gippert. I'm probably slaughtering your name. I'm sorry we didn't have Brenda's name on this slide, but we weren't able to change the font. So Jessica, can you introduce them for us, please?
Of course, yes. And people are writing in with some good the elicit questions. So keep an eye on those. Please keep them coming in as you got them. But it's my pleasure to introduce 2 of our FQHC colleagues and my colleagues, Brenda and Haley. So we've got a psychologist and a family doc with us, and at Denver Health, which is an FQHC network in Colorado, we've been running a constellation of healthy weight programs for a number of years now. We have them all sit under an umbrella called Healthy World. And I have to say, we have not been looking at it from this angle until very recently. And I really credit and appreciate Brenda and Haley for being some of our folks that have helped by really listening to our patients, their lived experiences, how they navigate our programs, what they enjoy, what they, what doesn't resonate with them, and, using that then as a platform to then do a deeper dive into the literature. At the end of the day, we want to be true partners with our patients, to the point that someone else made about this as a chronic disease. It really is less about kind of a short-term end result and more about, the long-term, camaraderie and support that we can provide to patients and families over their lifespan. So really excited for them to show you just some examples kind of from the clinical setting about how they've started to navigate these conversations in a different way, and then open it up for lots of questions.
Thanks, Jessica.
Thanks. Yeah, thanks for having us. Like Jessica said, my name is Brenda, and I'm the psychologist with our Healthy World programs at Denver Health. And so the majority of my work is with individuals in larger bodies. What's yours?
Yeah, and I'm Haley again. I'm a family doctor. I do primary care pediatrics and then also work in our Healthy World programs.
I think it's important to note that I live in a really thin and tall body. And so I come to this topic with a very privileged lens, and I just wanted to state that.
Yeah, I agree. As a thin white woman, I do have the same privilege Brenda acknowledged. And I think some of that privilege shows up in the fact that, as Jessica said, I've been doing this job for a really long time. And it's only recently that I've started thinking about weight stigma, and with the help of my colleagues, really making some changes to provide more weight inclusive healthcare. Right, next slide.
Next slide. Great. So we have some practical tips we're going to be sharing with you that help us practice more weight inclusive care in our daily clinical interactions. Next slide.
So our first suggestion is to notice your own assumptions about the connection between weight or BMI and health, and especially notice when those assumptions are wrong. So I'm going to show you a few examples of times that I've been wrong lately. Next slide. So this is a growth chart. It's a little hard to read with a bajillion dots in there, but basically this is a 12-year-old with type 2 diabetes. When I saw her in February of 2021, her BMI was 31, which was at the 98th percentile, and her A1C was 7.5. The next time I saw her was about 9 months later. Her BMI had gone up to 32. Her BMI percentile was up to 98.5. And so my assumption there was her diabetes has got to be worse. She also didn't take any medicine, by the way. So her weight went up. She didn't take medicine. In my mind, her diabetes is definitely worse. I'm wondering, like, is she going to end up on insulin? I'm going to send her to endocrine. I'm going through all these things. And then her BMI came back at 6.1. So what the heck happened? Well, her family had really struggled with food insecurity, and we set them up with a program called Denver Food Rescue, where they got boxes of fresh produce every week. She attended our MEND program for some education and social support around healthy eating and exercise. And then she got a skateboard, and she loves skateboarding and does that every day. So she controlled her diabetes with healthy habits in the absence of weight loss. And that was not what I expected to happen. Next slide. This is kind of the opposite. So this is one of my primary care patients. She's 16. Within the past year, her BMI went from the obese category to the overweight category to the quote unquote normal category. But at this last time I saw her, she was bradycardic, amenorrheic. She was losing her hair. She was passing out because she was really hardly eating at all and has anorexia. So my assumption, if I had just purely looked at her BMI, which is in the quote unquote healthy range, would have been that she's healthy when actually she's anything but healthy. When I look at this and think about this patient, I really wonder what words I might have used in some of those earlier visits that could have contributed to how this story played out. I also wonder how often we praise restrictive eating behaviors in patients with larger BMIs. Next slide.
Our next idea is to shift the focus from weight to health. And Haley has a great little intro that she starts her pediatric visits with. I'll let you do that first.
Yeah, so I start all of my visits by saying there's so many things we can do to be healthy. We can drink lots of water. We can eat all different food groups. We can do exercise. We can sleep enough. We can manage our stress. Which of those are going really well for you right now? And which of those are a challenge right now? And I kind of jumpstart the visits that way to start with the focus on health behaviors and also to normalize that we're not all doing all the things.
Mm-hmm. And I think sometimes older patients or parents are fixated on the number on the scale, and I try to qualify the number on the scale. So I ask them, hey, if scales didn't exist, how would you know you were making progress? And try to get them to identify other measures of outcome in their own lives. Or I might say, like, what would be different about you or your life if you were at that number on the scale? Like, what are you really looking for here? And I think a lot of times that we have to model this for our patients and our parents, because parents come in concerned about the child's weight. And even if Haley does her great little ditty she just did at the end of that session, the parent might say, okay, so how's my kid's weight? Like, what weight should my kid be at? because parents want to know that their kids are okay and that they're good enough parents. And so I think it's important to emphasize that we want to focus on habits rather than the number on the scale. Next slide. Oh, praise. So our next tip is to be intentional about praise. I am someone that loves to praise people. I think people are generally amazing and I like them to know it. And I think especially when people come in saying like, oh my gosh, my kid's BMI is improved or my weight's down. And I'm like, I just want to celebrate with them. But lately have been careful about that because I think praising someone for weight loss or maintenance truly perpetuates weight stigma. And I think sending that message of like, oh, you lost weight, you must be taking care of your health, or even more bluntly, you lost weight, so now you're good and you're worthy, are damaging. So again, really focusing on behavior changes and other outcomes that measure progress. So I'll usually say something like, sounds like you've been making a lot of changes in your habits. I'm wondering what you've noticed since you started making these changes. Like, any improvement in your energy? Do you notice any increase in strength or endurance? Like, are you running faster on the playground? Has your mood changed? Any? Do you feel better or any different in your body? So I try to kind of flip it to different outcomes to praise rather than the number on the scale or the growth chart. Next slide.
Right. Our fourth idea is to ask yourself or challenge yourself, do I really need to discuss weight at this visit? So if we start out by talking about healthy habits, we set goals around health behavior change. Do I need to talk about the weight at all? Or am I having an equal impact without the harm if I don't? The answer might be different in different circumstances, but asking the question, I think, is valuable. You could consider making weights optional. Sometimes that's a choice, sometimes that's not a choice. I would always, as Jenny mentioned before, ask patients permission before talking about weight. And then if patients ask about their weight or families ask about their weight, I'd encourage you to be really curious about why. Why is that number important to them? What are they making that number mean? Specifically looking for restrictive eating behaviors or self-esteem concerns that we could provide support for in a different way. When we do talk about weight, I'd encourage you to give that information in a neutral tone, neither congratulatory or critical. Mirror the patient's language, like Jenny already talked about. And then I really like to remind my patients, as we are talking about weight, that weight is just one of the measures of health and arguably not the most important one. I found that my visits feel a lot better and my relationships with my patients feel stronger when I am able to remind them that we can be healthy at any size. I tend to say some people live in larger bodies, some people live in smaller bodies. I want you to be healthy in your body, and then focus back on the health behaviors. Next slide. So our next suggestion here is kind of stepping back from your individual clinic visits and looking more for examples of weight stigma in your larger clinic or health system. If you can, write in the chat where places you've noticed weight stigma in your own healthcare setting. I'm curious if there's any that we're missing or that are not on this list, but I think about the waiting room. I think about having appropriate equipment, blood pressure cuffs that are the right size. I think about weighing patients in a disrespectful fashion or telling them their weight in a disrespectful way. I think about the number of patients who come in for a concern completely unrelated to their weight and then are given the recommendation to lose weight. We know that patients with larger BMIs are underscreened for some things and overscreened for other things. Here at Denver Health, we have a lot of BMI-based screening protocols, and there's good reasons for those. But I do wonder if looking at that one risk factor out of the context of the rest of them, we're missing something, and if that can be stigmatizing. And then access to various programs. So a lot of surgeries are restricted based on BMI. Also, our lifestyle programs here are restricted based on BMI in the other way. So you have to be a certain BMI to participate in our Healthy Lifestyles Clinic, which may imply that only people with higher BMIs need to have healthy lifestyles, which I would argue is not the case. Mm-hmm. Right, next slide.
Okay, so we're gonna zoom out even more and recognize that diet culture is everywhere. So as Haley and I sort of talk about these ideas or tips, we're by no means placing blame on anyone. I think that we breathe in diet culture in this country, so it's really difficult to get away from, and I think it's really difficult to unlearn. So I'm curious if you could chat in what comes up for you as you see this slide, and where do you see diet culture? Is it, outside our clinic? Do you see it in Hollywood and movies and TV shows, even at like water cooler talk, when somebody comes back after maternity leave, like, oh, you don't even look like you had a baby. Like, what kind of diet culture examples do you guys see in your worlds? I can't see the chat. As I said, as I made that suggestion, I can't see the chat.
I'll keep an eye on it as they come in. Instagram.
Yeah. Oh, we had a presentation with students that we did. We were like, okay, put in wellness in Instagram and see what comes up. And it's all like thin white women in very little clothing, eating, apples and stuff like that. It's crazy.
Yes, to another point that came in of that weight equals diet culture, right? Only a certain kind of weight fits in. Self-discipline. Devil Wears Prada quote. The rail thin Vogue staff says, "I am one stomach flew away from my ideal body weight."
Oh, one stomach flew away. Yeah, it's everywhere. And I think the important thing is that you can actually go to the next slide. The important thing is that we keep talking about it.
I think the more that we've had these conversations with our team, like debriefing after clinics and having retreats and giving presentations, the more I notice examples of weight stigma, both in my clinic and examples of diet culture in the larger sense. And so I think I am more aware of my own actions and words as well, since we've been talking about it. So that's our last tip, is to just have some conversations about this with your team and friends and family and whoever else. And I think we can really start making some changes.
Yeah. Notice it more. You build your own self-awareness. And I think that's where the process of unlearning begins.
Awesome. And there's a lot more stuff coming in too about other examples of diet culture, fitness glorification, exercising to quote, earn your food,
Yes.
Reading the word skinny on food labels, keto diet being all the thing everywhere. Yes. And so let's transition. If you have questions that you want to ask too, I can keep an eye on the chat. There was one earlier that I think it's important to mention, just in case someone did mention it or miss it. But someone had asked about the fact that as medical providers, we, are judged based on, do we note the BMI and the ICD-10 code in that visit. And, how do you kind of have those conversations while also putting in sometimes codes that use words still like morbid obesity. And Dr. Goodman from CDC did weigh in and is very aware of the issue, and they've been working to get those codes changed. So hopefully by October 2023. So there is hope. And Allie, if you want to weigh in here, fighting the good fight.
Yeah, thanks, Jessica. And thanks so much for that comment. We've been hearing that. And as a practicing pediatrician myself, I cringe every time I have to select those codes. So thankfully, CDC, the National Center for Health Statistics, which is within CDC, runs ICD, and they've been really approachable and great partners in working to improve those ICD codes. And we're getting to work with NAC and AAP and the AAFP and a bunch of other groups to try to improve those. And so we'll make sure that we get that person first language fixed. And also we're hoping to create pediatric specific BMI codes. So we'll have those added as well. So we're working on it. So hopefully we'll have those out and available with the October update of 2023.
Thank you. I'm going to sort of take over at this point, just to the next slide, because it's going together with what we're saying from our wonderful presenters. And you gave us lots of ideas of what we can do in 1 minute, 5 minutes, a 15-minute visit, or as we know, the 26 hours for the total lifestyle intervention package for people who actually are in the overweight or obese range. So I'm thinking, just from what you all put, is putting a sign in the waiting room and in the exam rooms that we oppose diet culture, and just like say it and have those examples. And how can we talk about health? I don't want to give people bad images, but how can we promote the good images? And some of that you can talk about in 1 minute, as we talked about with our motivational interviewing, or in 5 minutes. But what other questions and observations do people have? Specific questions, you're welcome to ask anybody. And save your questions for things like medical management, because that's the next module. So we don't want to talk, we're not going to talk about that yet. But more on bias, stigma, and motivational interviewing.
Getting lots of praise in here, guys, and definitely still, you know, some noodling through kind of what else can we measure and track. And, you know, Brenda has copied some into the chat too. And, you know, this is a work in progress, right? And I don't think, you know, sometimes we struggle within Denver Health because they take longer to measure. And so you have to do this one thing and it's easy. And, so just, you know, wherever y'all are in this, you know, there's always, it's like motivational interviewing for ourselves, right? There's always a little something we can do to work on, but you don't have to do all of it or it's too overwhelming all at once.
And thank you to the person that called out the social determinants of health on, you know, on that weight grid that was shown and said, you know, had all sorts of things that were listed as possibilities. So yeah, let's remember that. Next slide. So our next module is on the medical management, and there we are going to specifically focus on the categories of overweight and obesity. We won't be talking as much about the prevention, and we'll look at current practice guidelines as well as some things that are in flux. And people asked about comorbidity last time. We'll go more into depth on that and specific lab measures. So this will be more for those of you who are in exam room setting rather than in the community setting, but hopefully there'll still be linkages where you can see collaboration, and we'll have a wonderful guest next week as well too, actually. So any last questions for our presenters? Otherwise, we've got a CME slide, I think is next. Oh, resources, and you'll get all of these. So the Health at Every Size slide deck, it's very informative, the readiness ruler, and the studies that I talked about, you'll have.
All right, I'll take this slide. Hi, everyone. Sarah Price from NAC as well. Thanks to all the people who contributed today. It takes a team to put this together. So we would love your inputs. We are offering CME credits for this. And so for every hour you spent with us, and remember there's 5 hours total, you can get 1 credit per session. You do have to have attended today, as well as fill out an evaluation. So as you leave Zoom today, you'll actually be directed directly to a website, which will take you to that evaluation. We had 42 evals last time, which was awesome. We would love even more this time. And once you get those at the ends of the full series, I'll be sending out certificates that you can then have on file for your CME through AAFP. You can also submit it to other credentialing bodies as well for that CME credit. So again, we really, really covet your input into this. We take your feedback and make the next sessions even better. So please go ahead and do that. And thank you so much for joining us today. I'll hand it back to Jenny for closing remarks.
Well, that's it. Thank you, everybody. And again, thank you for contributing in the chat, and we'll summarize what's in the chat too. So take care and tune in next week, same time. Bye.